This lecture is going to cover neuroendocrine tumors of the GI tract, also known as carcinoid tumors. Just some brief things that we need to know about these tumors before we get into the more interesting things. So they come from the intrachromaffin cells, also known as the Kolchitsky cells. These are cells that are involved in neural signaling within the small bowel, and very specifically they release serotonin. They do have somatostatin receptors, which will come up later. The breakdown product of serotonin is 5-HIAA, which can be found in the urine of patients who have too much serotonin being released by their neuroendocrine tumors. The sites for these, this is frequently an ABSITE question. The number one most common is the appendix. Number two is going to be the small bowel, most commonly the terminal ileum, and then you see the others there. The other thing just to mention, these are associated with MEN type 1. However, MEN type 1 is more commonly associated with a thymic carcinoid, but small bowel neuroendocrine is on the list. Overall, there's a rising incidence of these tumors, and this seems to come up whenever you read about these. It's not entirely clear why this is. It's probably a lead time bias, meaning that we're just diagnosing more of these now due to ubiquitous CT scans as well as more recognition of these tumors. So looking at the things that are important to know about these tumors, we need to know the grade of the tumor, the stage, although that's really not super important for these, and then we need to know the primary site. So just to demonstrate why this is important, these grade 1 and 2 neuroendocrine tumors are very indolent and they do extremely well. So what you notice here on this figure is that the time frame we're talking about here is 120 months or 10 years. So we're talking about a very, very long time course, and these are patients with localized disease. You see about 75% of them are alive at 10 years. And then even those patients with distant metastatic disease, about 20% are alive at 10 years, and the median overall survival is somewhere around 3 years. So even in patients who have metastatic disease, these patients live for a fairly long time and have fairly indolent disease. So the next thing I'm going to show you here is, this is from a paper looking at metastatic grade 1 tumors, grade 1 and 2 tumors. So these are metastatic well-differentiated neuroendocrine tumors, and then their median overall survival by site. So what you see here is appendix, cecum, and small bowel all do very well. They didn't have a specific number for appendix, but they get lumped in here and they live for a long time. We're talking about 98 months. We're talking about 8+ years for metastatic disease. Colon and rectum, not so good. Stomach, not so good. Pancreas, somewhere in the middle. So what you see if you break it down here is the mid-gut neuroendocrine tumors tend to do the best and have a very long overall survival. Hindgut and foregut not so well. Pancreas is somewhere in between, but more along the lines of the mid-gut tumors. So the most common sites are the appendix, the small bowel. This is from a large retrospective database, so some of these cecal tumors are probably actually appendiceal tumors. But bottom line is these most common ones tend to do very well. Pancreas is also very common. Again, they do pretty well. The more rare neuroendocrine tumors are the ones that really do poorly. Another kind of housekeeping point before we really get into things is we have to understand that there's a big difference between neuroendocrine tumors and neuroendocrine carcinomas. So a neuroendocrine tumor is a well-differentiated tumor which can have these different grades based on the Ki-67 mitotic rate, which we'll get into a little bit. But the poorly differentiated tumors, which are called carcinomas, neuroendocrine carcinomas, do very, very poorly. These are different tumors entirely. They're more like small cell lung cancer than like any GI cancer. So these are just a totally separate class of tumors. I'm not going to talk about them much today, but if you ever see a poorly differentiated grade 3 neuroendocrine carcinoma, just understand that that is not a neuroendocrine tumor. And it does not fit any of the things that we're going to talk about in the rest of this talk. So these neuroendocrine carcinoids do not equal neuroendocrine tumors. They're treated with cisplatin etoposide chemotherapy like a small cell lung cancer. They are not treated with surgery, so do not operate on these patients. So the presentation of neuroendocrine tumors, much like other small bowel tumors, they present with kind of vague abdominal pain, can be very nonspecific. The abdominal pain can come from obstruction from the tumor, but also just from cramping, diarrhea from carcinoid syndrome or some vague symptoms like carcinoid syndrome. They rarely present with bleeding, which is unlike other small bowel tumors. They can be found incidentally on CT scan as well, and we'll talk a little bit about how they look on CT. So another thing that is often tested, although rarely seen, is carcinoid syndrome. So This is pretty rare. Only about 10% of neuroendocrine tumors actually present with this syndrome, but it's very frequently on tests, so we need to know about it. Serotonin, which is released by these tumors, is a vasoactive substance. There are some other substances described, but serotonin is a big one. So serotonin is typically broken down by the liver. So if it is released from the small bowel into the portal vein, it goes through first pass metabolism in the liver, and most of it gets washed out. So how do we get enough left over in the blood supply that it causes symptoms? Either it's coming from a place that isn't going to drain into the mesenteric vessels and go through the liver, like the lung or the thymus. So lung or thymic tumors are more common, are more likely going to cause this syndrome than GI tumors. Or you have a GI tract tumor that has liver mets, so now it's getting drained directly into the hepatic veins and bypassing first pass metabolism. Or there's so much disease burden and so much hormone being released that it just overcomes the ability for the liver to clear it. So the stereotypical symptoms are facial flushing and diarrhea. The easy way to remember this is that this is one that a colorectal surgeon taught me, is usually you have diarrhea and then you flush, whereas here you have flushing and then diarrhea. So if you can just remember that diarrhea and flushing go together, you'll remember carcinoid syndrome. The other things that you need to know: bronchoconstriction, likely, again, this is a serotonin effect within the pulmonary tract. And then the other thing we need to be aware of is carcinoid heart. So this comes from stiffening of the valves, and you get tricuspid insufficiency and pulmonic stenosis. The easy acronym for that is TIPS. So remember carcinoid heart, TIPS. Remember facial flushing and diarrhea and bronchoconstriction, and that's carcinoid syndrome. Again, not extremely common. The treatment for this is just giving somatostatin analogs, so things like octreotide, which we're going to talk a little bit about. But patients who have these symptoms, it can be managed generally with a somatostatin analog. And, a little more advanced thing to know would be that patients going to the OR for resection of a neuroendocrine tumor can have a carcinoid crisis in the operating room, which can cause hemodynamic instability. So they need to be treated with octreotide pre-op, and then they need to be on an octreotide drip in the operating room. So just something to keep in mind if you saw a test question like that. The way to treat that in the operating room is an octreotide drip. So talking about diagnosis of these tumors, we need to know how they look on CT scan. So this is a nodal met in the middle of the mesentery. So this is often how these will present, is you don't even see the primary. All you see is this big met in the middle of the mesentery, has a desmoplastic response around it, meaning all this kind of stranding of the mesentery around it. And you can imagine it's sort of sucking the mesentery down into this big mass, and that's how it causes small bowel obstruction often, is it shortens the mesentery so much that the bowel will get obstructed. So that's how the nodes look on CT scan. The primary tumors are going to be hypervascular tumors that light up on arterial phase. So this is an arterial phase CT scan because the aorta is full of contrast. And you can see these tumors are all hyperdense on arterial phase, and then they wash out on portal phase. So this is what metastatic tumors in the liver look like. But you can imagine the primary tumor, whether it be in the small bowel or the pancreas, also looks like this on arterial phase. And then the lab tests that will be specific to neuroendocrine tumors include chromogranin A and urinary 5-HIAA. So this is frequently tested. The problem with these is that they're not sensitive. So you can have someone with a totally normal chromogranin and have high burden of disease of neuroendocrine tumor. So we can't use these to rule out a neuroendocrine tumor, but they will often be elevated, and they're useful tumor markers. If you resect a tumor, you hope that value goes down, and then you can surveil the patient with serial chromogranin levels and make sure that doesn't rise. So these are specific but not sensitive, somewhat useful clinically, but often tested. You can biopsy these masses if needed. A lot of times you don't need that, but if they are biopsied, they'll stain positive for chromogranin and synaptophysin. Initial workup and staging. So honestly, the staging is too complicated for these because they're staged differently based on their site and things like that. I just wouldn't worry too much about the staging. We'll talk about management based on the site of the tumor and kind of which ones get resected when, but we won't go too much into the staging. So what do we look at on the path report? So again, we want to see differentiation. Well-differentiated tumors are neuroendocrine tumors. Poorly differentiated grade 3 tumors are neuroendocrine carcinoids, which again, whole different beast. Treat with chemo, don't resect, very aggressive, not anything like a neuroendocrine tumor. So within the neuroendocrine tumors, the grade is very important. The grade is going to be determined by the Ki-67 and the mitotic index, and you're going to go with the higher of those two numbers. So on the Ki-67, up to 2%, that's a low grade. 3 to 20, that's intermediate. Over 20%, that's high grade. Mitotic index, less than 2 is low grade. 2 to 20 is intermediate. Over 20 is high grade. So just remember 2 and 20. So if it's 2 or less, roughly, of either one, that's going to be low grade. If it's 2 to 20, that's going to be intermediate. If it's over 20 of either, that's going to be high. Again, if the numbers don't correspond, then you go with the higher of the two. And I would just say that when you get into these higher grades, you have to give a little bit of caution when you're taking somebody to the operating room, knowing that they're probably going to develop metastatic disease. But if you see these kind of very low Ki-67s, low mitotic index, you feel pretty good that resecting that disease is going to cure the patient, because their chance of recurrence is going to be lower. They're going to live for a long time. And those are the patients that you might do more aggressive resections. You might do a liver resection to try to clear them of their disease, etc. We'll get into that a little bit later on. All right, so other things on imaging. So you're going to get a CT scan. Again, the tumor is going to enhance on arterial phase. And then really we're getting CT scans usually to look for adenopathy. So this is particularly true in small bowel neuroendocrine tumors and appendiceal neuroendocrine tumors. If there's any evidence of adenopathy, it might change your operation a little bit, particularly on the appendiceals. And so you are really getting the CT scan to see if there's any evidence of adenopathy beyond the primary tumor. So let's say you had somebody that went to the OR for an appendectomy without a CT scan, and then they find a neuroendocrine tumor. They should get at least one CT scan just to make sure there's no positive nodes before you make your decision on whether you're going to leave them with just their appendectomy or go do a right hemicolectomy. So somatostatin specific imaging, this gets a little complicated, but I do think you need to have some idea of what's going on here. Basically, these neuroendocrine tumors typically have somatostatin receptors. So that's why somatostatin analogs will help to prevent them from growing and proliferating, but also it can help us use a slightly more sensitive imaging than just CT scan. So there's two options here. There's the Octria scan, or somatostatin receptor scintigraphy. This is the older version. This used to be used a lot, not so much anymore. Basically, octreotide, which is a somatostatin analog, binds to somatostatin receptors 2 and 5, mostly 2. Again, not super important, but if that was on a test ever, 2 is kind of the one that it really binds to. It gets coupled with indium, and then you can use basically SPECT imaging like you would for lymphoscintigraphy or something like that. It can also be done with concurrent CT scan to try to help them make the images look a little bit better. And then you're going to get imaging at 4 hours and 24 hours after the administration of the radionucleotide. Just kind of one ABSITE question that comes up. Octria scan does not work well for insulinoma, which expresses somatostatin receptor type 3, not 2. So that's really kind of a trivia question, but if you want to do really well on the ABSITE, you might want to remember that one. So here's some examples of these SPECT CT scans, and this is a tumor lighting up. This is a tumor in the pancreas lighting up because they have those somatostatin receptors, and so the radionucleotide gets attracted right to the tumor, and then it lights up. So the newer version of this is called dotatate scan. So the way this works, this little figure here kind of helps us see what's going on. So you have a peptide, a chelator, and a radioisotope. So you put the radioisotope in the chelator, and then you attach it to a peptide. Peptide then binds to the receptor. In this case, this is a somatostatin receptor, and then it gets taken up into the cell. The cell lights up on the imaging. Okay, so for dotatate, we have octreotate, which is why it's tate. And then we have gallium-68. So you're putting octreotide plus gallium together via a DOTA chelator. So it's dotatate. Gallium-68, dotatate. And then we use PET scan for this. So this is one big difference between Octria scan and dotatate, is that we're using PET scan instead of SPECT imaging. The clarity of the images is a little better with PET scan, so it's preferred. It seems to be a little bit more sensitive as well. So this is just an example. You have a regular CT scan, and then you have the PET imaging, and then you put the two together, and you get this PET CT that lights up these tumors really nicely. So the bottom line is dotatate uses PET, Octreoscan uses SPECT. PET is better than SPECT, so dotatate is better than Octreoscan. So basically, Octreoscan has fallen out of favor, and now everyone uses dotatate when they need this kind of imaging. So there's little data on this test so far. It's only been around for about 4 years, and nobody really knows what the indications are at this point. It does seem to have better sensitivity than just a regular CT scan and better than Octreoscan, but this is based on some small retrospective studies that basically showed it has better sensitivity for picking up nodal burden in small bowel tumors. So it seems like you're going to find the nodal disease better with these. However, again, it's based on pretty small studies, so I wouldn't go crazy there. So this is always the question is, when should we be doing these dotates? If you get a dotatate and you don't see any nodes, do you still have to do a lymphadenectomy? Do we think that it's sensitive enough that it could preclude lymphadenectomy when otherwise indicated? I don't think we're there yet. I don't think we really know that information yet. So why do you even get the dotatate if you're going to still have to do a lymphadenectomy? So should everyone get a dotatate prior to resection? I think on protocol, certainly everybody should. So a lot of big institutions are doing protocols where they give everybody a dotatate, and then they're kind of looking at those results. And then I think the most useful thing is it is very useful to establish a pre-op baseline. So if you're taking someone to the operating room and you think you're going to cure them, you get a dotatate pre-op, and if their tumor lights up, then you know that their tumor has those somatostatin receptors, and their tumor, if it recurs, should also light up with dotatate. So now you have a dotatate baseline. You say, yes, this tumor is dotatate positive, and now you can use dotatate as surveillance. You might not use it as your only surveillance, but if you see something questionable on CT scan down the road, you can get a dotatate, and if it doesn't light up, then you feel pretty good that it's not active tumor because this patient's tumor has lit up on dotatate before. So I think that's the most useful thing for dotatate right now. Okay, so that's going to end part one, and we'll come back with part two and talk about management of these GI neuroendocrine tumors.